Hey guys, today we're going to talk about the tibialis posterior muscle and all the components of this muscle. So let's start. This is the introductory slide, so overview. We're going to look at it's the deepest muscle of the calf. It's a key stabilizer of the foot and ankle and functions in arch support, weight distribution, and gait control. So it's a very, very important muscle. And that's why it's runner's nemesis, because a lot of the time if you are putting a lot of mileage through your legs, you will get issues with this muscle. Clinical importance. Dysfunction leads to foot pain, flatfoot deformity, and gait abnormalities. Common site for trigger points causing referred pain in the foot, heel, and calf. And it's important in differential diagnosis of ankle and any shin pain. So very important to look at this muscle anytime someone comes in with any ankle or shin pain. So referral pattern for the tibialis posterior muscle. As you can see, the trigger point's located right up in here, and it refers right into the Achilles and all the way down into the foot. So it's quite a wide referral pattern. Now let's quickly review the anatomical attachments. You can see its origin is up on the tibia, as well as the fibula, interosseous membrane as well, deep transverse fascia and intramuscular septa. So it's a very deep muscle, and that's why it does. It's one of the guys that is going to give patients a lot of issues. So it's very important to try and identify and figure out where it is, and that's why the origin and insertion is very important. So the insertion is even more important because, as you can see, it kind of goes right. The tendon passes behind the medial malleolus, and it runs deep to the flexor retinaculum and superficial to the deltoid ligament. And inserts mainly on the navicular, which is right in here, plus the calcaneus. You can see it also has a little bit of an attachment to the calcaneus. So that's why if someone comes in with plantar fasciitis, it can very well be potentially also coming from the tibialis posterior. The cuneiforms and the bases of second and fourth metatarsals. So as you can see, this muscle is very, very important for any sort of foot control. So anyone that comes in any foot pain or even any shin pain, it's so important to look at this muscle. Now let's look and see what's how this muscle helps when it comes to weight bearing, as well as walking. So it distributes weight across the metatarsal head, so it's a very important shock absorber. Shifts load towards the lateral foot, supported by the strong plantar ligaments. Restrains valgus thrust on the ankle, and prevents excessive pronation and medial spiraling of the leg. And this is the medial spiraling of the leg. It also is also important for that whole cascade, the knee and the hip. So it's a very, very, very important muscle. And then prevents excessive lateral inclination of the leg during the mid stance. Its dynamic role assists plantar flexors in controlling tibial advancement over the fixed foot, and also aids in knee stabilization. In non-weight bearing, it inverts, adducts, and assists in plantar flexion. It's also a co-contractor with the peroneus longus, and it helps support the medial arch. So because of the fact that on the other side, the peroneus longus, it comes from the other side. So these guys almost kind of create a heel lock type of mechanism around the ankle, the peroneus longus and the tibialis posterior. Activity is increased with faster walking speeds and higher muscular demand, same as running. So it's going to be more activated during those activities. Dysfunction and weakness of the tibialis posterior. The consequences of the weakness is outward turning foot in gait and standing. So I'll show you that. And the reason why most likely patients are turning the foot outwards is because of the fact that that improves stability. It's more biomechanically stable to have your foot out rather than using the muscles. Obviously, we get excessive pronation, and it also leads to the flatfoot deformity, loss of arch. When you do get a tendon rupture of the tibialis posterior, you get the flatfoot deformity, and one of the things that I look for is when someone does come in with a flat foot on one side and then a normal arch on the other, that gives you an indication that could have been some trauma. So it's always good to look at that as well. Symptoms and differential diagnosis. As we reviewed before, the referral pattern, the primary symptoms are pain in the sole of the foot, Achilles tendon, mid-calf, and heel. So it's quite a wide area of symptoms. It's worse with walking and running on uneven surfaces, and it's triggered by increased stabilization demand. So let's say if someone goes for a longer run, they get the symptoms, well, that could be the problem. Differential diagnosis, you can have shin splints, overuse, stress at the tibial attachments. So these are all the muscles that are attaching onto the tibia. There's other muscles that are involved in here as well. Chronic tenosynovitis, that can also be, but the trigger points in the chronic tenosynovitis, they kind of run hand in hand. So there's different stages of tibialis posterior tendon dysfunction. Early stage, minimal pain, weakness on single heel raise test, pain and tenderness near the medial malleolus and the navicular, and conditions often correctable with conservative treatment. Now, when it gets, you've seen some patients like this in the clinic where there's a complete collapse of the arch. Now, and this is called too many toes sign because you can see quite a few toes when a person's just standing. So basically the radiograph showed that the forefoot is abducted, calcaneus and navicular subluxed laterally, and this often requires surgical tendon repair. So when you see a patient like this and they're looking to improve with physiotherapy, it's highly unlikely because it's a chronic condition. And then you can see here in the stage 3 gets even worse. So that is why it's so important to get them, look at their feet, get them to stand and see how their feet are in standing and also single leg standing rather than just trying to work on the calf. I always, whenever someone comes in with any calf or knee pain, I always look at the feet as well to see how they're functioning. So here, when it comes to trigger point examination of the tibialis posterior, this muscle lies deep in the leg, so you have to press in deep. There's no other way. It's not directly palpable, and it's accessible only indirectly through other muscles. So you have to tell the patient that you got to press a little bit deeper. And I would suggest trying to palpate up in this area and a little bit on the lateral aspect, which is, as you can see what they're doing here. So in this area, and then also pressing straight in, moving the gastrocs out of the way and then pressing straight into there. And I often use this technique to basically dry needle. You can dry needle the tibialis posterior or do shockwave or hands-on therapy. Those are all different ways that you can kind of get at these trigger points. Is there anything else? Yeah, and tibialis posterior, if you really get at this muscle and work on it, and what I tend to do a lot of the time is even shockwave down into this area here, just because of the fact that it's these are the tendons and they respond quite well to shockwave therapy. So I would shockwave down here and then try and get at these muscles, whether it's hands-on or even shockwave, or with dry needling is quite effective. But the tibialis posterior does respond well to conservative treatment. And here's the summary slide. So tibialis posterior is essential for foot stability. The attachments are very, very important. Once again, if you're a physiotherapist and you don't know where the origin and insertion of the muscles are, you are really gonna miss out on treating your patient, because you have to understand where each of the muscles is originating from and attaching, because then that way you can truly understand where to treat that muscle. And that's the whole point of this series. Its function supports the medial arch, prevents overpronation, aids in gait control. Symptoms of dysfunction, foot and heel pain. This is when we want people to come in. When you start getting this excessive pronation, the muscle is already starting to basically lose its ability to work effectively. And then pes valgus deformity, this is when people have to start getting into surgeries and the quality of life goes down. So when someone's having that foot and heel pain, that's when you really got to get in and try and figure out what the problem is, rather than just giving him a couple of stretching exercises. You have to look at the trigger points because it does refer to all these different areas. And the importance is early recognition prevents progression to fix flatfoot and having to do surgical intervention. You wouldn't believe how many seniors I've seen, they're not able to walk because of the fact that they have this deformity where the foot is all the way. And when you're 75, 80 years old, no one really wants to touch you and do these types of surgeries. But that's what happens over time. So that's why when it comes to your patients, get them to try some taping, get him to try some orthotics, because all these things offload that area and keep that joint, the ankle joint, in place and in good position, rather than that foot adducting. Because once that happens, then you got to look at surgical interventions, and those are often quite painful, and not many people want to go through with this. Other than that, thank you for tuning in, and have a great day.